Good morning, everyone. Thank you for choosing to come to this session. I know we have a room full of busy maternal and child health experts who are pulled in numerous directions. My name is Brooke Jones, and I am joined with Lauren Quick-Graham this morning, and our presentation is addressing injury and violence to prevent pregnancy-associated deaths. So today we plan to provide an overview of the North Carolina Maternal Mortality Review Committee, discuss some of the national data, and provide a call to action for those who are working in maternal health. So the CDC has made 39 awards supporting 39 states and 1 U.S. territory for the enhancing reviews and surveillance to eliminate maternal mortality, or the ERASE-MM program. One of the states supported by the ERASE-MM program is North Carolina. Lauren and I both work as social work abstractors. Our members are appointed by the North Carolina legislature, and the committee is a multidisciplinary team that reviews all perinatal deaths through 365 days postpartum. It's really important to have some background on the nuanced terminology surrounding maternal mortality review. So for example, the ICD-11 defines maternal death as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from unintentional or incidental causes. So these violent deaths, suicide, homicide, and overdose, those are typically captured by the more comprehensive term of pregnancy-associated deaths, which is defined as the death of a person while pregnant or within 1 year of the end of pregnancy from any cause. So with that, I'm going to turn it over to Lauren, who's going to discuss some statistics.
So these are national statistics. Some of you may already be familiar with them, that were released by the CDC. Just as Brooke said, so I'm going to add on to what Brooke had just shared about definitions. So as you'll notice, this slide is entitled Pregnancy-Related Deaths, and the title of our presentation is Pregnancy-Associated Deaths. So pregnancy-related deaths are determined by the committee. And as Brooke had said, it's a multidisciplinary committee. So all deaths, Brooke and I, along with our team of abstractors, gather medical records from hospitals, behavioral health providers, you name it, for every death that vital statistics or other sources of information, they identify this person was either pregnant or up to a year postpartum following the end of a pregnancy. So this includes pregnancy loss. And so we gather that information, we present it to the committee, and the committee determines if that death was pregnancy-related, pregnancy-associated, but not related. And then the third category is pregnancy-associated, but unable to determine if it was pregnancy-related. So I wanted to give that caveat and to avoid confusion. So for those that have been awarded the grant, these are the statistics for pregnancy-related deaths. So the committees determined these deaths were related to pregnancy. And as you'll see, mental health conditions is the leading cause of pregnancy-related deaths, followed by hemorrhage, cardiac and coronary conditions, infection, and then injury. And so sometimes injury can encompass DVI, PV-related deaths. So I wanted to kind of put that out there. And the reason mental health conditions is combined is often, it's hard to determine, was this a suicide or was this an intentional overdose or an unintentional overdose? I always are afraid to use those terms, but that's what is discussed. You can go to the next slide. So we just wanted to present some statistics just to give you kind of an overview of how severe this issue is. So a fifth of all deaths during pregnancy in the first year postpartum are related to homicide, overdose, and suicide. The chance of this probably is much higher. Substance use related deaths and homicides have increased over the past decade, and we also know that they've increased as a result of the COVID-19 pandemic. Rates of suicidal ideation during pregnancy has increased by 100% over the 10-year time span. Again, does not include COVID-19 pandemic, with wide racial disparities. And among Black individuals, prenatal suicidal ideation has increased by 700%. So before we get into DV/IPV, overdose and suicide screening, we wanted just to go over some general screening guidelines. And so these general screening guidelines are so important to follow. We want to be screening people when they're alone. So not when family is present, not when partners are present, not when anyone else is present. So when they are alone with us, we want to screen everyone. We don't want to select. We want to screen universally. We always want to offer a screening tool in the person's native or preferred language. We want to use the person's pronouns. We want to use validated screening tools, which we'll go through during our presentation. And it's important that we're following screening guidelines and directions. So each screening tool will have at the top, usually at the top, specific guidelines for how to use that screening tool. And it's only validated in that way. So if it might be a verbal screening where we ask the questions as providers verbally, it could be something that we hand the person to fill out, or they might fill it out on the computer. And something else that we think is really important is really considering the role of integrated healthcare teams. So something we often hear is like, providers don't have time to do these screening tools. Well, A, that shouldn't be an excuse, but B, consider if that particular provider is saying that they don't have the time or the capacity, think about other people on the team that could do screenings. Because a lot of these screening tools do not require that you are a specific profession. Some only require that you're a licensed provider. Some actually don't have any requirements. And so really consider maybe a doula or maybe a peer support specialist, in addition to social workers and other OB/GYN providers, can also implement these screening tools. And an easy way to make sure that you're screening everybody is just to include it in your routine paperwork and assessments. Again, screen everyone regardless of their suspicion, and I'm going to talk about urine drug screens in a second. And screenings are really only as good as the community resources we know about, right? So we also need to be familiar with what to do after a screening. And so coming up with resource lists, anything that you can think of to help person if they screen positive on any of the topics that we're covering about. And it's really important that you attend trainings like this one and other trainings that are specific on screening tools so that you know how to implement the screening tools, you know the risks associated. And I'm going to go back to urine drug screens, and this may come up a little bit later in our presentation, but typically ACOG and ASAM are not recommending urine drug screens. And the reason for that, there's a couple reasons for this. First of all, urine drug screens don't always pick up substances. There's also, for some substances, there's a short detection window. I'm thinking about like cocaine. And then there's some substances like marijuana where a person, someone in the perinatal period, they could test positive for marijuana, over a month. And so really it's not a good measurement tool. And another reason why it's not effective is urine drug screens are also very expensive. And sometimes insurance does not cover that. So what ends up happening is the patient is left with the bill, and they can be quite pricey. So I'm a clinical supervisor. I do clinical supervision. And one of the most frequent questions I get is like, how do I know screenings are important. I just don't know how to introduce them. I feel like people think I'm targeting them by introducing this. And so Brooke and I came up, you may have seen similar framing statements before, but this is just a sample of a framing statement you could use. So we've started talking to all of our patients about safety in relationships, because it has a huge, such a large impact on your health. And then you can go into the screening. And I'm going to pass it back to Brooke to talk about DV/IPV.
So if you are screening specifically for intimate partner violence, some direct questions that you can ask are, has your current partner ever threatened you or made you feel afraid? Has your partner ever hit, choked, or physically hurt you? For those who are of reproductive age, You may want to ask, has your partner ever forced you to do something sexually that you did not want to, or refused your request to use condoms? Has your partner ever tampered with your birth control or tried to get you pregnant when you did not want to be? And for those with disabilities, has your partner ever prevented you from using a wheelchair, cane, respirator, or other assistive device? Now this slide and the next slide, we wanted to just introduce and give you all some additional kind of literature that's out there that discusses research in the area of violent death. So, you know, this one is from Marchson et al., who looked at National Center for Health Statistics data as well as CDC Wonder data across 33 states and DC, and they found that deaths due to drug use, suicide, and homicide constitute more than 1/5 of all deaths during pregnancy and the first year postpartum, and that homicide as well as drug-related deaths had increased over that decade, and that decade, as Lauren pointed out, was prior to the pandemic. This research also found that pregnancy-associated homicide deaths occurred disproportionately during pregnancy compared to the postpartum period. This next article related to, it's a Wallace et al. Article, and they looked at homicide during the full perinatal period, so again, through that 365 days, and found that homicide is a leading cause of death during pregnancy and the postpartum period in the US, and that pregnancy and the postpartum periods are times of elevated risk for homicide among all females of reproductive age. So, you know, some things to consider in terms of maternal health consequences that are linked to intimate partner violence. Folks are twice as likely to miss prenatal care appointments. They're more likely to initiate prenatal care later than recommended. They're twice as likely not to initiate prenatal care until the 3rd trimester, and they're more likely to miss 3 or more prenatal appointments. You know, Lauren and I, throughout the records that we see, you know, we will often, you know, kind of note in prenatal care that someone is being described as, quote, non-compliant. And then later, you know, because of the record, maybe in an NMHIS report, when the cause of death is not directly homicide, it'll be noted that there was a domestic violence history, or because of the cause of death, we know it was homicide. So some risk factors. In terms of, you know, the literature provides some clear risk factors related to perinatal homicide that includes younger age, race, really racism, and a previous history of intimate partner violence. So I want to talk a little bit about racism. So while previous literature has identified race as a risk factor, the literature and the conversation now is acknowledging the historical trauma of the US that led to structural racism and this complex interplay that we have between social determinants of health, race, and health. So when it's acknowledged that victims of pregnancy-associated homicide are more likely to be Black, it's important to acknowledge that this isn't due to biology. This is a result of social constructs and social structural racism. I also really want to point out, related to this last bullet point in terms of previous history of intimate partner violence. So this came from a study that was from a maternal mortality review committee out of Virginia. And, you know, MMRC data, it's considered the most complete and contextualized as it includes multiple data sources. You know, we are able to look at healthcare records, police records, ME reports, behavioral health care records sometimes. And, you know, it's more difficult to make statements about intimate partner violence if you're only looking at death certificates, because in the case of homicide, a death certificate does not state the relationship between the perpetrator and the deceased. So this is a really important point when not every maternal mortality review committee looks at the full perinatal period or accidental or incidental.
So in terms of overdose deaths, we know that, just like nationally with non-pregnant people, drug overdose mortalities increase, but within the perinatal population, it's increased nearly 81%. And we were fortunate to receive a grant from the CDC to specifically look at our cases from 2016 more closely, our overdose deaths. We found a quarter of the deaths were related to opioid overdose. And I want to give a little kind of note here, a footnote, if I will, is that it's really hard for us to look at cocaine or methamphetamine overdose deaths specifically, even though we know nationally, like statistically, those are also increasing. And the reason for that is what Brooke said with DVIPV, we're getting a lot of information from death certificates. And so on death certificates, for those of you not familiar, cocaine overdose and methamphetamine overdose could be cardiac arrest, which is heart attack. It could be other types of cardiovascular issues. And so the cause of death would look like that. And unless we have more information about their substance use history, it's really hard for us to tie the cocaine or the methamphetamine as other substances to the death. So I want to give that caveat because we get that question a lot of why specifically opioids. But this is a very concerning number. And again, this is 2016 data. And so we are currently looking at more recent data, and we anticipate that this number is going to be higher. So in terms of risk factors for overdose, in terms of specific risk factors, we know that a loss of the custody is a huge risk factor. So loss of custody could be from CPS. And I know that Brooke and I have a special interest too in finding out if pregnancy loss also has a link between overdose and suicide. Also, past history of overdose is a risk factor, mixing opioids with other substances, trauma, not receiving medications for opioid use disorder. And I also want to draw attention to that because it's no longer, or we're encouraged to call medications for opioid use disorder, not MAT, medication assisted treatment anymore. And if we have time, I'm happy to answer a question if someone has a question why. And as Brooke had shared earlier, intimate partner violence is also a risk factor. In terms of validated screening tools that we can use during the perinatal period, we can use the 4Ps plus 5Ps. NIDA has a quick screening tool. There's a substance use risk profile pregnancy screening tool, and the Wayne Indirect Drug Use Screener. I know in North Carolina, we do the 5Ps. That is what every health department at least uses to screen for perinatal substance use. Harm reduction, I know like sometimes we get, when I bring up harm reduction, they go in pregnancy, but we have to be considering that first of all, not everyone's goal is abstinence. And for some folks, abstinence really isn't always kind of the best avenue, or it may take some time. So to meet someone where they are, we have to think about harm reduction. I don't have a lot of time to talk about harm reduction today, but here are some harm reduction strategies. The first is naloxone rescue kit. Really, we should be encouraging and connecting anyone who discloses either current or past substance use or has a prescription for opioids, naloxone rescue kits. And we have the opportunity to connect people to get test strips. So I'm sure you all have seen in the news, overdoses are very common. Test strips are a really good way for us to encourage people to use them, to test what they're using before they use them, to see if there's any harmful substance that can relate to overdose or can increase your risk of overdosing. So we're going to transition to talking about suicide. So it's so important that if you all just remember this, because suicide is actually in the perinatal period is most likely to occur 6 to 12 months postpartum. And so as many of you know, because you're in the maternal health field, screenings at that point have usually stopped. And I know, as being an outpatient provider who worked at just outpatient treatment, I know that it's not a very common question where we're asking people when they're coming in for an assessment if they've been pregnant within the last year. I'm talking about like behavioral health treatment outpatient. So I'm encouraging providers that maybe are not in maternal health field to be including that in all of their assessments, to be asking people, have you been pregnant within the last year? How many pregnancies have you had, et cetera. And for those in the maternal health field to kind of keep this statistic in mind, that I think that this really challenges our perception that suicide could happen this late postpartum. And yeah, it's okay, you can go forward. So some screenings for suicide. So the Patient Health Questionnaire, PHQ-9, is an evidence-based screening tool. The Edinburgh Postpartum Depression Scale also has a question about thoughts of suicide. Now, it's really important if someone is disclosing that they are, to question number 9 on the PHQ-9 or on the Edinburgh, if they're responding that they are having thoughts, that you follow up with like, what are the nature of the thoughts? Do they have means? Do they have intent? Because simply answering that question, yes, you have to get more information. And for those who are, you're concerned acutely about their risk for suicide, there's the Columbia Suicide Severity Rating Scale. And something I want to point out, that the Columbia Suicide Severity Rating Scale is really for people that have suicidal ideation. So it's not necessarily a screening tool that you'll do with everybody. It's people that you really want to assess their level of risk. In terms of risk factors for suicide, you all can read the slide, but again, DV-IPV is one of those risk factors. History of child abuse. So again, a lot of social determinants of health here. Difficulties sleeping, which we know as maternal health providers, that's very common in the perinatal and postpartum of the perinatal period, especially postpartum. Having a depressive disorder, an anxiety disorder, and being high risk. And this is just a sample I wanted to show you all about the Columbia Suicide Severity Rating Scale. So now we're going to focus the remainder of our time, the next few minutes, on really a call to action. So after I'm done talking, I'm going to pass it back to Brooke because I know she has some points that she wants to talk about. But the first thing I want to talk about is documentation before I get to nuanced terminology. So you may have heard Brooke and I talk about death certificates. We're gathering a lot of our information from death certificates, but I want to remind everyone something that we probably all learned in school. So if we didn't document it, it didn't happen. And so often we hear when we're going through cases, the committee members will say, there must have been a screening. There must have been. How was this missed? And I swear we hear that every meeting. I don't know, Brooke, correct me if I'm wrong, but we hear about it every meeting. And the truth is we don't know if these screenings are taking place because there's no documentation. So this is one thing that we can definitely do. The other part with documentation is we really want to document objectively, not subjectively. So we want to be moving away from this frequent flyer, like harmful language, like frequent flyer, non-adherent, compliant, and really be looking at more objectively what's going on. We want to be using person-centered language. And the thing I stress is Brooke and I are reading these records, and some of you may be surprised, some of you may not be surprised, but some of the language even that providers use, it's pretty pejorative. We've had records of substance use I can speak of, from the top of my head. We hear providers use the word junkie. This person's a junkie. We've seen treatment being refused because, they're not worth it, or they're just going to go back and use. And we're actually reading this. And again, some of you may not be surprised, but sometimes I'm just taken back by how strong the language is within the medical records. So again, I encourage you all to, if you need to, get some training on documentation, but to read over your notes. And for those who are leaders in the community, doing chart audits and seeing if this is trainings and staff need. Resolve nuanced terminology. So as Brooke had shared in the beginning, really getting on a standardized, kind of more standardized definitions of like the perinatal period and stuff like that. In terms of standardized data collection, Brooke also shared that there are some committees and there are some states that will only discuss certain cases based on the medical examiner's death certificate. So there are some states, and we want, to encourage states to review all deaths, but we have heard of some states where if they'll see a motor vehicle collision death, they won't review that because they think it's an accidental death. And Brooke and I can speak to many instances where we've abstracted a motor vehicle collision death, and it's actually been a suicide, or it's been, substance related. We had one case recently that was deemed a DVIPV related death. The partner grabbed the steering wheel and went into a tree. So, I just want to encourage people to be thinking more about kind of this idea of what's on the death certificate. There's always a story behind that. Again, examining maternal deaths through the entirety of the perinatal period. Like I said, suicide is most commonly happening 6 to 12 months postpartum. And again, we want everyone to be fully investing in the violence prevention efforts, screening, again, learning your resources in the community. And Brooke, is there anything that you wanted to add for the call to action?
The only thing I think, Lauren, you've covered, everything that I would say, with one exception. I would just say for those who are working in clinical settings, please ask loved ones to step out of the room. And I also supervise new social workers in the field. And I have found that is something that feels really uncomfortable for a lot of folks to, say like, okay, well, it's wonderful that you're here. I'm so glad, is there any concerns that you have? Okay, and at this portion of our visit, I'm going to ask you to go back to the waiting room, and I'm just going to finish up with some other tasks that we have for the day. And that is where you can introduce some of these other screeners, right? This is where you can start with those framing questions as well. It's critically important that we do that when we are talking about IPV and DV, specifically, but also, with depressive symptoms, anxiety symptoms, you just really don't know if family members are supportive, if there is a family culture that is going to support being honest about what is going on in the perinatal period. And so we just want to make sure that we are giving folks the privacy that they need. I saw in the chat that there was a question about the framing statement. So I wanted to go back to that. Here it is. So, we've started talking to all of our patients about safety and relationships because it can have such a large impact on them being able to move on to more specific questions or screening tools.
And we had some really great suggestions in the Q&A. So one participant had mentioned that they're looking into enhancements, and they actually don't let partners in their sessions, OBGYN visits, for the first 5 minutes. And that they are suggesting using signage in treatment room bathrooms, like with secret code words, so that the patient can tell the provider. In terms of whether or not this is an effective intervention, I don't know. Brooke may have some information. I mean, that's something I know that she and I are very interested in ourselves, and we'd be happy to look up. And we'll put our emails up if you all want copies of the slides or if you have any further questions. And then another participant shared, and this is so essential, that even if patients are not able to share what's going on during that particular visit that you're screening, you can always continue to ask, and we should always be continuing to ask. And here, because we're about out of time, we got a minute left, and we've enjoyed presenting to you, but if you have any questions, if we've left, without answering your question, or if you would like copies of our slides, please take down our email addresses. We'd be happy to connect. Both of us are also on LinkedIn. And we just want to thank you all for attending and giving us part of your morning.
Thank you, everyone.